Hello, good afternoon, everyone. So we'll be starting the INASL LTSI Symposium Liver Transplantations. We have got three eminent speakers in this sessions. So at the outset, as the first speaker, I would like to invite Dr. Sanjeev Saigal. I think he doesn't require any introduction in this forum. He is one of the most distinguished hepatologists of this country. So he'll be speaking on optimizing a sick liver transplant recipient, hyponatremia, cardiopulmonary, and sepsis. Dr. Saigal, please.
Thank you very much for the kind introduction. I would like to share that from this year, we have started this new initiative of INASL LTSI Symposium. And on a reciprocal basis, when we have the annual LTSI meeting in November, we'll have an LTSI INASL Symposium. So this collaboration, I'm sure will go on and will actually increase further. And I'm truly delighted to present the first talk of this newly generated symposium. It is on a very interesting topic. I think everybody in his day-to-day practice encounters patients who are sick, have various problems, and it's pretty much challenged, to be honest, and there's no clear answer to this, let me tell you. It all is an experience-based decision, and you may be right or you may be wrong, but it's up to you how you take the call. It's an appetite of the team looking after the sick patient, how much you want to take a risky patient for a surgery, and especially people like me who are in living room liver transplant, it becomes all the more challenging when we have a donor and a recipient lying there and the family has a pressure. But what happens? You have a patient who's hyponatremia in ICU, very common problem actually. It leads to a lot of problems. If you see, there are tons of literature which says that hyponatremia pre-transplant is not a good thing, but we see it all the time. This is a published paper 2 decades back, nearly. Excellently done study. It shows that if you have significant hyponatremia, you have more neurological problems post-transplant, more infectious complications, more renal failure. So it's known. So the challenge is if somebody is in your ICU, the sodium is 122 or maybe 118, and everything is set for transplant, he's a very sick patient, you have to take a call, and the next day or the 2 days later is the transplant. What do you do? There are various ways you can handle this hyponatremia. As a policy, it's a slow correction, fluid restriction versus hypertonic saline. You've got Vaptans, and of course, there should be a plan. Now, this is one of the plans which I actually, for a presentation's sake, took from one of the recently published nice article. So you have to have a preoperative plan, intraoperative, and a postoperative plan. Idea is that whatever you do, reduce your attempt to increase sodium drastically. That is a fundamental thing, and we all know that. What do? You restrict the fluids, stop loop diuretics, correct potassium, and do normoglycemia. We often don't give credence to these other things, and we must understand that all other metabolic parameters should be in place if you want to correct hyponatremia. Then, preoperatively, you have a choice of albumin or Vaptans, depending on the situation. I'll come to that later on. Intraoperatively, my surgeons are very good in this thing, and the anesthetist who works in our team, and earlier Dr. Vora was in Medanta, I've seen them, they're very, very good in not allowing sodium flux more than 6 millimoles in the entire surgery of 12 to 16 hours. So that is very important. And don't have these delta changes. Limit sodium containing IV fluids, limit sodium containing blood products, see what you use for your clotting correction, and if needed, do a low sodium CRRT. We do all these as per the situation. And post-operatively, again, you would not just give way. You should continue to take care that the sodium changes are not happening much. If you started with a surgery at a sodium of 125, I mean, it should be 128, 129 post-op ICU. Even in post-op period, it should be not more than 130, 132, 133. It should not be that you start at 125 and post-op day when it is 140, 145. It's a disaster. Very important thing. In the earlier days when I was in Gangaram Hospital, I'm aware of this. Me, Subhash, Dr. Soy, and we were there together. And the patient would come from OT. He's like bloated, full. And I see sodium is 140, 155. And I say, what's happening? I had no clue what's happening. Then gradually understood that fluid management in that 14, 16 hours of surgery is the most crucial part. then that is completely in the hands of the excellently trained anesthetist. So we all know this. We have hyponatremia correction by IV albumin. We use it as and when needed. We have hypertonic saline. Again, most of us know that we don't use it easily. Well, if sodium is less than 120, you may use it, especially if patient has seizure. But we should not have more than 8 to 10 millimoles of rise of sodium while we are correcting with hypertonic saline. Well, I do use it often on, but there's a desire or other pressure from my surgical team that sodium is low, you have to make it okay in the next 12 to 16 hours or next 24 hours because the patient is to go to theater the other day. I think it's a complete, like eyewash. What happens if you artificially correct a sodium from 120 to 130 or 130? It may make you feel happy that patient is going in a good situation, but if you do the thing within 24 hours and you just rush the patient, give hypertonic saline, I think you've done more bad for the patient than good. So that's tendency under any reason to just have a figure in your charts which is like good looking so as to allow the patient to go to surgery. I think that tendency should be not encouraged at all. And I always now like to present papers which have been published from our own centers, our own centers in the country, and our own publication. This is a paper from Dr. Rela's team in JCH. Well, it's a nice one. It shows out of 520 patients, group A, 125 and low, B, C, and D is like almost normal. So these patients were studied. Impact of hyponatremia, does it matter? Well, clearly higher MELD, SBP, AKI and all, they had more problems. Bottom line was that if you avoid a delta shift in sodium, which I was talking earlier, that is a single most factor which allows you to have a good outcome in the post-transplant period. That is a message from this paper, nicely done one study. Then tolvaptan, we all are aware, we do use it often on selective vasopressin V2 receptor antagonist. It really brings up sodium very nicely. There's no question about that. You use it 7.5, 15 milligrams, you see that it rises 24 hours. But preoperatively, it is not to be used, especially it can have a sudden severe rise and you have a problem. So be very careful. If in the sicker pre-transplant patient in the ward, you're going to use it, be very careful. So this is in a snapshot, a policy which I follow. It's not from any journal. It's not from any publication. This is I would say my experience of over 5,000 transplants. If I have a sicker patient in ICU, sodium more than 130, I'd proceed straight away. 125 to 130, I would restrict free water, give IV albumin, and try and wait for correction 1, 2, 3 days if time allows. Lesser than that, again, I may use Vaptans in a selected situation. Well, if there's an emergency, you actually can proceed for surgery. Believe me, it doesn't really matter to that great extent if you're careful and don't allow sodium fluxes in the period. So if you start with the low, keep it low all through the surgery, the day 1, day 2, and you gradually can tide over the crisis. Of course, less than 120 is something, it's not so good situation, and this has to be taken care of carefully. You may have to buy time. You may have to give 3% saline, but this patient needs to be carefully taken for surgery. I am aware of patients, especially in my team, our surgical team is very, very proactive, and we have taken sodium of 112 also, 114 also, and patients have recovered and done very well without a problem. But I always tell to my team or fellows that if you have one patient with 112 who does well post-operatively, does not mean that that's a practice. It is a one-off patient, you've done well, excellent. But guiding principles are, don't let sodium fluxes happen in the theater. Post-operative also maintain the same thing. And if you follow everything, I think you should be fine. So cardiovascular, again, it's I know it's a very tight time for so much of thing to discuss, but just to give you a snapshot, you all know everything, all these things in I'm sure. Again, this is a consensus guideline from LTSI. I'm very happy to present this guideline. You all should read it. It's Shweta did a great job. Charles was also involved in this. So that we have our own guidelines now, and as a representative of LTSI, I make sure that we should have our own guidelines based on our own experience, and that should be promoted. Pre-LT, well, we have this, all these standard parameters. We all are aware of all these things. TEE, we don't use much, but I think that we had a recent, workshop in the last meeting which we had, and TEE is a very, very crucial thing, and we must learn to do it. Anesthetists are doing in our hospital. They can be trained in a way. Some of them are very good I mean, they're just inherently trained in that. But TEE has a strong, role if you are having a sicker patient in ICU. A very complex looking algorithm. Don't worry about this. I think this is more important. If you have a situation, we have done an angiography and you've got a patient who's got a CAD, what do you do? Non-obstructive CAD, you can go ahead with some, antiplatelet agents. But if you have put a stent, you have to have some time, 3 to 4 weeks. Even as a single agent, you cannot use clopidogrel in these patients. But yes, complex left main disease or complex CFSL disease, you may have to do combined CABG and transplant, which we have done successfully. And I think many of our centers who are doing heavy volume transplants, both in North and South, are actually good in doing these complex surgeries. I just read a report from one of the centers in South. They did, I think, aortic valve replacement and CABG and transplant. I think yesterday only I saw it on one of the social media sites. So that's very encouraging. So we can deal with these things. What one must be aware that cirrhotic cardiomyopathy can unmask post-transplant. Everything is fine. Patient has got good EF of 50%, and then post-transplant, day 1, day 2, you find that suddenly the EF drops 15%, 20%, especially in alcoholics. And I've seen this happen more than once, actually quite a few patients, because it was a cardiomyopathy alcoholic which unmasked in the post-transplant period, and patient went to heart failure, and I have to use intra-aortic balloon pump. So one has to be aware of all these things while you're dealing with such sick patients. POPH, mostly a very, very tight situation, but if you have got after good diuresis, after good challenges of Lasix, you still have a PA pressure which is more than 45 to 50, well, you have to be very cautious. Such patients may not be candidates for liver transplantation with that level of PA pressure. HPS, we had a good experience. Narendra with me, we wrote an excellent paper on this. Our own experience, which I still think is one of the best in LDLD scenario from country to country. About 7 patients had severe or very severe hepatopulmonary syndrome, very well managed, sicker patients, needed pre-op, all the measures, post-op ICU care, ventilation, and so on. But nearly all of them actually survived and did very well. Now the series is much longer, much bigger, but this was a decade back. So I think that HPS we can deal very nicely in a very sick ICU patient. Now sepsis, again, we must know that culture positive sepsis is a problem. So this is the last part, is the thing I would like to answer. Test all is, I think you all know. Can we transplant patients with active bacterial infection? Now this was answered partly in this excellent article by Elizabeth Werner, which I would like to place in this short talk today. That risk of surgery versus immunosuppression and or positive in culture is a very, very difficult situation. You should be treating the active bacterial sepsis. Don't take somebody with fluid culture positive. Fungal culture positive is a no. But yes, sometimes if you have one of blood culture positive or urine culture positive, I would go ahead and do a sick transplantation. I would not hesitate in that. ACLF patient in ICU, sicker patient, my resident says, sir, a culture has come positive. I said, okay, don't worry. He needs the transplant tomorrow. We'll probably go ahead. We'll not just on one report, especially urine culture, we'll probably go ahead. But if you have time, you should obviously try and get your antibiogram, see what is the best antibiotic and how you can control that. But those are, situations one has to understand. And a 1 to 2 weeks interval is an ideal before you proceed for surgery. So in a sicker ICU patient, but as a protocol, understand how to monitor these patients, learn the SOFA score. Many of you, I hope, are doing it. You should do that. Do biomarkers, do procalcitonin CRP whenever needed, antibiotic de-escalation, and so on. So end of the day, it's the multidisciplinary team approach. Very important that everything is being discussed on a day-to-day basis. In ICU patients, I think twice a day meeting must be there between hepatologists and the ID people, ICU and all, regular MDT rounds. And with that, I think one can really, take care of these critical threats, and perhaps, with a judicious management, you can have a good outcome despite very sick patients with sick complications. Thank you very much.
Thank you, Dr. Sanjeev, for excellent presentation. The question, answers, and discussion will be at the end of the session.
Thank you. Sitting here?
Yeah. So, for the second talk, now I would like to invite Dr. Neeraj Saraf. He is also a renowned hepatologist. He will be speaking on immediate post-transplant care, what a hepatologist needs to know. Dr. Saraf, please.
Thank you. I'd like to thank INASL for inviting me here. So immediate post-transplant care, what a hepatologist needs to know. So I'm not sure if we're talking about a hepatologist working in a transplant unit already, a transplant hepatologist or a non-transplant hepatologist, but yeah, so I can see most people here are non-transplant. So that's why I kept the talk simple, and I'll just give a overview of what a hepatologist should know after a patient undergoes transplant. So the hepatologist should know the general care of a recipient early after liver transplant in a normal course. So what happens to a recipient, what are the timelines, immunosuppression, etc. And a hepatologist should know when and what can go wrong. So we'll discuss some of those in the immediate period. And immediate period, it's not really defined, but I'm going to take it as about 4 weeks from transplant. So I'll run through a case and I'll discuss what a hepatologist should know and what are the problems which we face. So this is a 46-year-old male transplanted for decompensated chronic liver disease, diabetic, hypertensive, obese. He had frequent LVPs or TIPS was done a few years ago. Then he started developing encephalopathy, and then a transplant was done last year for MASL-related CLD. So these are just some donor details, nothing abnormal here. The GRWR was slightly on the lower side, so we had done a biopsy, and the recipient details, because the GRWR was low, we usually do a hemiportocaval shunt in these patients, and he had normal, not a very high transfusion requirement and unusual surgery. So after a transplant, we need to have a holistic approach to the patient and not, as a hepatologist, just look at the liver. So you need to know, I know there are anesthetists and there are critical care people in the ICU, but you need to know things about ventilation. You need to know the hemodynamics of the patient. You need to stabilize the renal functions. Fluid balance is extremely important. Cardiac care, knowing the cardiac complications. I'm not going to go into details of these. Pulmonary, extremely important because these are one of the most frequent causes of morbidity and mortality, pulmonary infections, especially post-transplant. Graft, we must know how to maintain a graft function, and we must know what to do when there is graft dysfunction. Antibiotics use has to be known, antifungals, antivirals, when to use them, which one to use. Infectious complications, prevent infections, treat infections, extremely important as a hepatologist, because again, we know that probably the leading cause of morbidity and mortality after transplant is sepsis. Immediate surgical complications, one needs to know. It can be vascular, hepatic artery thrombosis, portal vein stenosis, and biliary complications like bile leak. We must know the immunosuppression management, and of course, nutrition is extremely important immediately and early in the post-transplant period. So I'll talk a little bit about normal. So what a hepatologist should know. So these are the group of drugs which are commonly used. The CNIs, mostly we use tacrolimus, MMF, corticosteroids, mTOR inhibitors, and in some cases of induction, you use antibodies like basiliximab, and very rarely you use B-cell inhibitors like rituximab. So this is a standard immunosuppression which every hepatologist must know what is used after transplant. So it's triple immunosuppression. Usually you give a loading dose in intra-op period, 500 to 1 gram, and then you give about 20 to 30 milligrams after surgery, and you taper it off in the first 2-3 months. Tacrolimus is given 0.1 to 0.15 milligrams per kg, and mycophenolate in a dose of 500 to 1,000 milligrams per day. TAC levels usually should be maintained about 8 to 10 initially, and then maybe about 6 to 8 over the next couple of months, and then you can probably lower them down further. Nowadays, we are using a lot of mTOR inhibitors, especially in cases with HCC and in patients who have renal dysfunction. Even de novo use has been described, but usually we'd like to start them about a month after surgery because they're known to cause delayed wound healing. Antibody induction, again, I'm not going to go in detail. Sometimes when you have renal dysfunction, then drugs like basiliximab can be used to avoid or delay the introduction of TAC. Infections, again, extremely important. Like I said, prophylactic broad-spectrum antibiotics must be given. Antifungal like fluconazole must be given. The commonest causes of infection are indwelling catheters, surgical lines, IV lines, central lines, pneumonia, and surgical wounds. And this is just a time frame of various infections that take place. And obviously, in the early period, you have bacterial infections, fungal infections, and you can have viral infections. And as the timeline increases, the spectrum changes, and you can have other infections like Aspergillus, Mycobacterium, etc. Again, continuing with what is the usual or normal. I'm going to come to abnormal after this. So post-transplant nutrition is extremely important. And I think as hepatologists, we must know when to start nutrition. So this is what we usually follow. Day 1 of surgery is NPO, then you start with oral clear liquids. On day 2 to 4, soft diet if the liquids are tolerated well. Obviously, if you have to be specific if fluids are restriction is needed. And day 5 onwards, you can probably give them normal diet, and usually the patients are shifted to the ward. But what is important is on the below is about calories, about 35 kilocalories per kg per day, and we must give them a very high protein intake of 1.5 to 2 grams per kg per day. So coming back to the patient, he had an uneventful first week. Labs were within normal limits, hemodynamically stable, on-room air shifted to the room, cultures are negative. Liver Doppler, as per protocol, were all normal, and he had a drain which was decreasing and less than 100 ml. So this is his post-op course, and if you can see, just like to focus on the last line on day 10 and 12. So till day 8, his graft is doing reasonably well. His enzymes are almost normal. Day 10, the SGOTPT start rising, and on day 12, he has a slight increase in TLC, which is 12.4. The AST and ALT are 189 and 237. So there is a beginning of graft dysfunction. Now let's look at the differentials at this point. So for patient at 10, 12 days, what can be the causes of graft dysfunction? This every hepatologist must know. So it can be early allograft dysfunction. Dr. Soin is going to talk about it later. You can have bile leak, you can have vascular complications, you can have rejection, you can have ischemic reperfusion injury. Sepsis is always a differential, and although day 12 it doesn't happen, but early on primary non-function is something which we need to know. And these are the time frames of major complications. So first week, hyperacute rejection, primary non-function, and second to fourth week, you have rejection, hep C recurrence, which nowadays we don't see much, and sepsis, hepatitis, etc. Surgical complications are usually hepatic artery thrombosis, bile leak, and portal vein thrombosis. So when we approach a patient with graft dysfunction, you have to have a holistic approach. So it's not just the enzymes or the enzyme pattern or what. You must go into the background of the patient. You need to know what was the etiology of the liver disease, what was his pre-transplant MELD, what were the surgical details. That's why I showed them here. They may or may not be relevant to this case. You must know what was the donor history, statosis, recipient post-transplant history. So all these help us in managing or diagnosing or thinking of what that patient's graft dysfunction could be. So labs are obviously done, imaging is done, liver Doppler, MRCP, CT as required, and a liver biopsy if needed. So this patient had, we ruled out sepsis, although his TLC was slightly high. Viral serology was negative, there was no leak. CMV DNA was negative. Vascular complications were not there, Doppler was normal. Cellular ACR was obviously an option, so a possibility. So we did a liver biopsy on day 12. So the biopsy showed mixed portal inflammation, predominantly eosinophils, some ductulitis and endothelitis, and he had a moderate rejection with a score of 6/9. And this is a mixed inflammation, mostly eosinophils, and here you can see some ductulitis, endothelitis, and ducts are not very clearly seen here. So he had acute cellular rejection. We gave him 3 boluses of 500 milligrams and then tapered it off, and he had a completely normal recovery, and LFTs became normal. So For diagnosing rejection, you must rule out other causes of graft dysfunction. Like I said, you must do a Doppler, and the treatment is usually pulse therapy. You could give 500 milligrams, 5 bolus doses. Some centers use 1 milligram, 3 bolus doses, and taper accordingly. Some other causes of graft dysfunction, which we all must know: primary non-function. This is more common in DDLT, occurs in about 3 to 5% of allografts, and is almost it's a deadly condition. Presents as acute liver failure, encephalopathy, coagulopathy, jaundice, and you need immediate retransplant. Otherwise, you lose the graft and the patient. Hepatic artery thrombosis, again, something which we all must know. Early usually occurs in about 5 to 15% patients. More common in pediatrics, less in adults. And color Doppler is the first line of diagnosis. And if you suspect that, then a patient should undergo a CT angiography or MR angiography. Early on, if it's the first week or first few days, then surgical revascularization is the treatment of choice. If it's later than that, then you can probably do a IR revascularization to treat hepatic artery thrombosis, and sometimes patients need a retransplant as well. Early graft dysfunction, small for size syndrome, these again occur in the first few weeks, and they're sort of a form of a ischemia reperfusion injury, and you need a bilirubin of more than 10, INR of more than 1.6, and evidence of portal hypertension in the form of usually ascites after transplant to call it small for size syndrome. I think Dr. Soin has a lecture on this. So I'll quickly wrap up. So this patient was doing well. At week 4, he again had high enzymes. AST/LT went up to 296 and 341. And so the spoke remains almost the same, except that in the previous one, now I put across. So usually at 4 weeks, you will not see early graft dysfunction and small for size. You have some new differentials like disease recurrence, Hep C mainly, which we don't see much now, and you could have hepatitis. Bile leak, bile vascular complication, rejection, sepsis, they all remain at 4 weeks, a differential diagnosis. So workup for this patient was done. Doppler was normal. CMV DNA was not detected. TAC level was 6.6, just increased the TAC a little bit. And viral serologies was negative. There was no biliary dilatation on MRCP. Now, what would we do? He had a recent rejection. Should we just monitor the patient? Should we increase his immunosuppression, empirically? Would you just give him empirical steroids, or would you like to biopsy the patient? Now, this is a very important message I want to give: always biopsy, because, and this especially to my junior colleagues, that don't get tempted to give steroid boluses thinking that it's probably going to be rejection. So this is what his repeat biopsy showed. Sorry. And here you can see these are fuzzy cells, which is CMV. And here this is a CMV immunohistochemistry stain showing a classical CMV. And we treated this patient with IV Jancyclovir initially, and then Valjanciclovir 900 milligrams twice a day. And what was odd in this patient was that CMV DNA was negative. So you can have this situation where CMV DNA is negative in blood, but you have tissue CMV. So this is just to summarize. Evaluation of graft dysfunction after transplant. I've already gone through most of these. So if you have IR injury, usually conservative treatment is what is needed. Vascular complications, do a Doppler, a CT angio, re-exploration, or IR-guided thrombolysis. Biliary complications, do a MRCP and follow it up with ERCP or PTBD. If it's early, then obviously surgery is better. Sepsis, do cultures, antibiotic-guided therapy, change the IV lines, change the catheters. Small for size syndrome, medical management, sometimes you can do a portal flow, inflow modulation. And we have used plasmapheresis in some patients with good results. So my take-home message: treat the patient as a whole and not just as a liver or a graft. Antibiotics use must be done judiciously. Infections should be prevented. You must optimize the renal functions, the cardiac functions, know the fluid balance, give good nutrition, no immunosuppression, tailor it when needed. Have a holistic approach to graft dysfunction. Just don't see the enzymes. Go into his previous history also. Recognize graft dysfunction early. So I think for a lot of treatment options are surgical and IR, but as a hepatologist, we must recognize the problem, know the differentials and the timeline so that you can work up the patient accordingly. Most of the treatment is teamwork between surgery, intervention radiology, endoscopist, hepatologist. And again, a very important message which I want to give to my junior colleagues especially is not all graft dysfunction is rejection, like I showed in this case towards the end. You must biopsy the patient before thinking of steroids because it can be something else. It can be CMV, it can be some other infection. Thank you.
Yeah, thank you, Dr. Neeraj, for that excellent talk. And please join us for the discussion. I think Professor Soin is on his way. So we'll take up the questions for the first two talks now while we wait for Dr. Soin. So the topic is open for discussion and any questions from the floor.
Sanjeev, sir. Hello. Yeah. So, sir, in the pre-op optimization of liver transplant patients, one of the things we commonly see is low albumin levels. Now, in normal surgeries, low albumin levels, there is concerns with healing and all. But in decompensated cirrhosis, it's often difficult to bring it to, optimal levels. So, what's your approach for that?
So, I mean, you have to have, you cannot correct the albumin to the normal level, right? The patient is cirrhotic, decompensated, so they are going to be, hypoalbuminemic. So I think that's a part of the surgery. So I won't really, sort of, jack up the albumin and try to make it normal. Sometimes they go to fluid overload actually. And unnecessary albumin use actually can be more problematic. You can unnecessary fluid overload the patient just before the surgery, and that will be bad actually.
So is there a minimal albumin level at least you target, or there is nothing?
You say
like
albumin, right?
Yeah, albumin, yeah. Is there a minimum level before sending him to the surgery?
No, I don't think there's a minimum cutoff. I think if patient has got 2.8, 2.93, you just have to do it. I don't think that precludes surgery. Well, if it's better, it's better for that. But I am sure many of my patients would have gone to theater with low albumin less than 3, and that's not a no for the surgery.
Good evening, sir. Good to hear you again. And you stressed a lot on rapid correction of hyponatremia. It should be very cautious. So, if it is rapidly corrected, if you see after the patient has come from ICU, as you have said. So, apart from the neurological complications, we see that it can patient can have pontine myelonolysis, or it can cause increased mortality. So what are the other complications you see? Why you are so much worried about rapid correction and the high levels you see after post-op?
Well, that's a nice question, Rahul. I think, again, great to connect with you. So the two parts of the answer. One is that if you have hyponatremia significantly low, like,
Yes.
about 120, 122, 130, it is well known that it itself is a predictor of post-transplant complications. It's been shown on multiple
Yes.
papers, both neurological, sepsis, graft dysfunction, all right. Now, rapid correction, I think, leads to huge, fluid shift changes, and especially the brain. The hyperosmolarity does make an impact on that, the glial cells and all. So, the fundamental concern which I still have is the concern of, okay, I tell you. Now, sometimes we say that you do an MRI, says or CPM is not there. Okay, we are concerned with CPM, correct?
Yes.
But I think there are all stages which you pick up. You don't always pick up on this thing, but you'll find that if you have corrected the sodium rapidly and there is some mentation problem, I think that's an issue. So otherwise, I cannot say that it leads to any other major disastrous complication on his cardiovascular or renal. I can't say comment on that. My single most concern would be the neurological, and I've seen a couple of patients actually, which have been somehow inadvertently given rapid correction of sodium. Not correction actually, they have been inadvertently corrected in the OT actually, theater. They have had a huge flux of sodium. So that is, and then I've seen post-operatively they have had a bad outcome mentation wise. So I think that, to my mind, still remains the main concern.
I think
I've seen probably more CPM post-transplant rather than yes.
That's a
lot of
that's a
times
point
you
actually.
see
Yeah.
on day 5, day 6, or
In fact, we have seen this in our previous
you
webinar.
rarely see it in the pre-transplant when
Yes.
the patient is cirrhotic, but you do see it sometimes after transplant.
SBP positive patient, when you are preparing the patient for transplantation, and then positive blood culture. So how long will you wait, and when will you decide to transplant this patient? And do you think PCT has got any role in this situation?
So your first part is SBP positive,
Yeah.
right? Are you telling that patient is SBP positive and the culture also is blood culture? Is that or a separate
No,
question?
separate patients.
Okay.
One of them is SBP positive, the
See,
other one is blood culture
right.
positive. Yeah.
If it's somebody has got a SBP, and I have picked a pre-transplant, I would certainly like to treat the patient with proper antibiotics. If I have it's very uncommon to have a peritoneal fluid culture also. You don't get, mostly it's a cell count based diagnosis most of the times, right?
20% we have culture positivity.
Yeah,
as
if
well.
you get it
in the
fine, then you
ascitic
base
fluid.
it as per your antibiogram. You should
Yeah.
treat that. I think we should definitely treat for 3 to 5 days before we take them for surgery. Uh, uh, Again, sometimes you may have a pressure in LDLT that okay, given 24 hours, 40 hours, and go. I think as surgeons
Yeah.
would tell me more. I think that 3 to 5 days, 3 days minimum, we should give antibiotics properly. Some protocols, I don't know. I think Vedanta, we're following that. We would do a repeat tap before patient is in surgery to show that cell count has come down. Now, which may or may not be, a universal practice. So that's one part of my answer. Blood culture positive, if you ask me, culture positive has two components. One is a patient has blood culture positive, has got typical sepsis and sepsis related issues. Absolutely no. Don't touch that patient. I would not take them for transplant. And LDL is a huge undertaking. But we all have, faced patients. There was a protocol that day -1 samples are sent. I don't know why they are sent, but they are sent, right? And you do the transplant on second day of surgery, you find that the sample sent date -1 was actually culture positive,
Yeah.
right? What can you do? You have done the transplant, but I've seen that it really doesn't matter too much. Patient was otherwise stable, sick patient, obviously. Then you do the transplant and everything goes on well and it's fine. I was seeing that paper by Dr. Pamich is here, right? I think I may be wrong, but I will ask you this question. He's an ALF publication which he did,
Mhm.
and when I was presenting a slide on ALF for some reason, I was going through his paper. I think if my memory is right, he's written 40% of his ALF at culture positive. So if that is so, firstly, let me confirm if I'm right or wrong in that. But he has written in the paper 40% at culture positive. Obviously, they had a transplant they went through. So, Dr. Pavicha, can you take up the answer on that?
Yeah, please.
Okay. Yeah, 40%. Yeah, 40%.
My memory is good.
culture
Thank you very much.
positivity in ALF. And to be honest, if we take Indian data on infections before transplant, so our experience, we just analyzed more than 900 patients with CLDs actually, excluding ALF and other patients. So the infection rate is upwards of 40%. Overall infection rate before transplant. And many of this are actually MDR bugs or XDR bugs, which is very horrible situation actually, to be honest, pre-transplant to have. So you were talking about 1 in 2 is having infection before the operation. Okay. Then we try to analyze actually what should be the ideal timing of transplantation in patient who had sepsis. And then we divided the groups based on week, 15 days, and then 1 month and more than 3 months. Like those, we divided the groups. And what we found was it was 27 days was the cutoff from being infection to transplant. So if your duration of that is less than that, then you got a high morbidity and mortality after transplant. And this applies. So that's why Indian patients are very different than what we learn from literature. Cadaver transplant, that's a very different ball game. To be honest, immunosuppression, I know Neeraj has written 500 milligram is in methylpred on reperfusion. I don't think we never given 500 on reperfusion because our patients are so sick, refractory ascites. They have median ascites on table is 10 liters. If you give 500 milligrams of methylpred on table to this guy, he's not going to make it up. So we give only 100 milligram of methylpred on reperfusion. And then, we wait until everything is good to give further immunosuppression. So we taper it out 80, 60, for next 5 days, and then TAC will come in only when kidney is good and urine is pouring out. So our patients, they don't require that much immunosuppression, to be honest. That's something we need to be careful when we talk about literature and ourselves.
But in ELF, if you are going to wait for 27 days, your patient will be either awake or will be dead.
No, this is not ALF. That's why I said not ALF. So ALF, blood culture positive, then you just give the antibiotic, and then you have to go and hit the patient with a transplant, because that necrotic liver need to come out, otherwise patient won't survive. So you don't, blood culture positivity in that situation is very different. Even ACLF, actually you treat with antibiotic, patient is good, hemodynamic parameters are good to go for transplant, you should take the patient for transplant.
So I just put the context, but I don't want to convey a message that culture positive patients can be taken for transplant. It is not the right message. If the culture positive, try and avoid, as simple as that. And 100% if the sepsis is there, patient is septic, I mean, no question, you should not take the patient. But sometimes you got a culture positive flags up, and you have to, what do you do the next day?
I think hemodynamic stability is really important.
Yeah, I think so. Yeah.
Dr. Neeraj, nice talk. And just one question to you. So how do you monitor these patients from POD 1 to 7, just for the hepatologists out there? So how do you, in your practice, how do you monitor them after transplant?
So I think, like, obviously you have labs every day. I think first few days we do Doppler twice a day, and then after 3 days usually one daily for the first week at least. Any abnormality, like I showed you, do a imaging or an ultrasound or a CT scan. If there is infection or counts go up, usually do a CT abdomen to look for any collection, anything that can be drained. Obviously change the lines. So, and nutrition again, like I said, is important. So I think daily labs, imaging as needed, nutrition, and obviously weaning off from the ventilator, shifting as early as possible out of ICU. I think these are the things, and I agree with Dr. Pamicha that immunosuppression is, patients die of infection and not because of rejection. So immunosuppression can be kept low, can be delayed. So we hardly ever use any induction with bacillus, because I feel that you can just not give anything for the first couple of days and nothing happens. In fact, if you give, our experience with basiliximab is not great. Patients die of sepsis. So I think low immunosuppression and general management over the first week.
Hello, sir. The question to Neeraj, sir. I wanted to know about, like, in ACR, we usually give pulse therapy for 3 days, and then if it's not working, we consider it as a steroid resistant. But few consultants may extend the methylpred for day 4 or 5. Like, according to your experience, like, when we can call it as a ACR, 3 days, or can we give to on 4th or 5th day also?
So what is written everywhere is 1 gram bolus for 3 days. We have never used it. So we've never given more than 500 in 1 day. So we usually give 500 for 3 to 5 days. That's our experience, and it's worked. So if a patient doesn't respond to that, so 5 boluses of 500 or 3 boluses of 1 gram, and then you repeat a biopsy, and the biopsy still shows rejection, that is called steroid resistant rejection. I personally don't believe much in steroid resistant rejection. I think you're dealing with some other etiology, or there's something else going on. In last 10 years, I don't think we have seen a single steroid resistant rejection where I had to use ATG or anything else. So I think it's extremely rare. If you give a proper dose of steroids, most people will respond.
Thank you, sir.
How do you balance immunosuppression if the patient goes into sepsis in the early post-transplant period? What is your...
Yeah, so that's tricky always. I think it's a fine line. I think there's no science there. I think it's just based on, I think, like, infection. Again, like we were talking of pre-transplant infection, what does the infection mean? So with just slightly high counts or something, I would probably give the normal immunosuppression. But if there's evidence of sepsis or organ dysfunction, patient is going into hypotension or renal dysfunction, then obviously you need to
When do you start tapering that? Or do you taper that, or you stop that, or
So let's say a patient is on day 10, usual immunosuppression, let's say on 20 milligrams of methylpred, 3 to 4 milligrams of TAC, 500 milligrams BD of MMF, and we think he has developed sepsis. Then if it's frank sepsis, hypotension, AKI, then I would hold TAC, I would hold MMF and just give him a small dose of steroids. That's all. But if it's infection, not sepsis, not organ dysfunction, you could probably maybe just lower down the immunosuppression or even just keep it same also.
Another aspect is this is for both the hepatologist and Dr. Pamesa also, if he's here. Does it, the context of DDLT and LDLT in presence of infections? Because in LDLT, you have got the, luxury of choosing your time of, transplantation. You can wait for, say, around 1 week, 10 days or whatever. But in DDLT, say the organ is, available and your patient is, kind of, septic, but is not very sick. In that situation, because you cannot, just give away the organ, so that the logistic is there. Does it influence your decision of doing a transplant at that point of time? Does it?
So I think, LDLT, I think you have the luxury of waiting, and I think it's always better. So I would think that there's less infection. But I think even in DDLT, I don't think you would, just because the organ is available, and if the contraindications, I would still think are the same. Maybe a surgeon can answer this, Dr. Pamicha. So if a person is septic and you have an organ, you still wouldn't give it to him, you would give it to the next guy in the line.
Organs are precious.
Active sepsis is always a contraindication. So if you got a patient who is in active sepsis,
say you have got a blood culture positive and you have got a sensitivity pattern is there. You know the organism. Say it is E. coli and it is sensitive to, say, imipenem, meropenem or whatever maybe. So there is a chances that you'll be able to take a life. So
no,
in that situation,
come on now, I won't transplant a patient with blood culture positivity. If I've got a graft, DDLT graft with, you got a recipient with blood culture positivity, I won't transplant that.
I think most people won't.
No, you should not actually, because that graft, you can't just take it as that this is his best chance, because that graft can be used for somebody else actually, who might be a better this one, because that's an active sepsis. And even in patient who are in SIRS, like you have culture negativity, but you got an in-house patient who's in active SIRS, who's got tachycardia, his tachypneic, having temperatures. So that graft has to be used for a more appropriate patient rather than transplanting.
Yeah, I think that's a very logical approach, because end of the day, the organ is
because it's
precious.
always temptation. I can understand, when you have limited grafts coming in and then you see for a recipient, this is in-house recipient, okay, I had lots of those things, but I never budge onto this. You need to have an appropriate recipient to transplant.
that happen actually sometime in our practice actually. Even the donor is positive, culture is positive, then you are in a dilemma. In an ideal world, definitely it goes to the next person, but in our country it is next to impossible. Sometimes we offer
I can
or the
see
organ
that availability of a recipient,
but it is not
a-
utilized, I'll tell you.
Yeah.
Many a
So
time it
in that
happens.
situation, Dr. Kaman, when you have no recipient available, no other recipient available to use that graft, then you have a justification to do it. But upfront to do it when you got another recipient available, then it is, it won't be right to do that, because then you are denying someone who would have benefited from that. Donors again depend. Donor, active blood culture, which has been enough antibiotics have been given, and you have that window of 24 48 hours where antibiotics have been given, slight rise in count, slight transaminase, those you can take it because it's a whole liver graft, and somebody is going to benefit from that graft. So it all depends on all other factors to look into.
Definitely, it is in DDLT. Basically, we'll do DDLT in our center program is mainly DDLT, and it is such a dynamic situation, and the window of opportunity is so less. At that point of time, you have to decide, and you don't have too many persons whom you can consult. So it is your decision. Sometime logistically, sometime ethically, morally, you are kind of not very clear what you are doing at that point of time. So that's what that's why
I think this dilemma will continue, and I think it's an individual call which the center has to take at a time. Yes.
If you have a list available, that the only solution to all these problems is that you have a good waiting list available, there where you have, you know, that if there is a problem, I can call in more recipients, at the last moment to transplant. So those are the solutions forward, so that you don't get into. So have you transplanted anybody with blood culture positivity, and what happened?
No, that is the thing. But we had that kind of situations
Yeah.
where we have to forego the harvested organ. Actually. So that is another.
I mean, in that situation, if you want to transplant, then you can justify, okay, we don't have a recipient, we'll do it. Mhm.
Definitely. Thank you. Yeah.
Yeah, I think Dr. Soin is still on the way. So we will break for tea, and he'll give his talk in the next session.
Thank you very
Yeah,
much.
thank you all the speakers.
Everyone. Yeah.
Hello. Thank you so much. Chairpersons and speakers, please join us for a photograph. We just have 10 minutes break, and I request you all to rejoin.